Hello, my name is James Waldron and I'm a GP working in Nottingham and the First 5 lead for the Vale of Trent. And I also co-host the GP Notebook study groups. Welcome to the GP Notebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. You can find us on all major podcast platforms, including Spotify, Apple Podcasts and Google Podcasts. Please follow us to receive notifications about new episodes, and if you like what you hear, please consider leaving a review to help other listeners find us. You can also follow us at Twitter at GP Notebook for more information about new podcast episodes and study groups. Finally, you can visit GPnotebookpodcast.com for podcast episode show notes and GPnotebookeducation.com to find out more about upcoming study group meetings. In this episode, we'll be discussing dermatology and skin of colour. It gives me great pleasure to introduce you today, Dr Thuva Amuthan. It's the second time he's joining us, and Thuva is a fellow First 5 GP, and he's also a GP with specialist interest in dermatology and elsewhere known as Dr Derm, a keen educator in all things skin, and I'm really glad to invite him back today. Welcome.
Thank you, James, for having me back.
It's great. It's great to have you back. We had a really good podcast the last time. We were talking about dermatology in primary care and dermatology in the community. We covered things around eczema and psoriasis and acne, and particularly the thing I remember mostly from last time is that encouragement of routine, the holistic approach to dermatology care, and using emollients and using even more emollients and stopping using soap. But at the very end of that podcast, we touched on a little bit about treating different ethnicities and people with and skin of colour. So that was quite interesting. We thought we'd devote an entire episode to it because it's such an interesting topic. So I'm going to come back to you, Thuva, with this. Why is it important that we're aware of how dermatology differs in skin of colour?
Thank you, James. I think this is, like you said, it's a very important topic and it's something close to my heart and passionate about. Now, You say, why is it important? There's a couple of reasons for that. One, historically, all the textbooks, all the literature has been based on Caucasian skin, and there's very little material available for us to understand skin of color, skin and hair presentations. Number two is that people of different ethnicities have different physiological and anatomical features in their skin that determines how different skin, their predisposition to different conditions and how they present, what treatments they need, and the consequences and complications they have because of that. And I think that's why it's important. In a globe where mixed race is the ethnicity that's growing at the fastest rate possible, we have to address this before it's too late. And in the UK, where we're such a diverse population, with the metropolitan areas not purely being diverse, but also the rural areas getting more diverse. And I think it's something that we have to address to reduce that inequality that has been forever widening.
Yeah, absolutely right. I couldn't agree more. So, I mean, what sort of things, if we were to focus on a few things today, what sort of things should we be aware of? What sort of things are important for us to look at?
A couple of things we have to be aware of is the psychological impact of skin and hair conditions that can have on a person. And unfortunately, not a lot of things are funded on the NHS because of cosmetic reasons or classed as we normally know it as procedures of less clinical value, PLCV. And because of those, what happens is in skin of color, most patients are left with unmet needs that we as doctors have been trained or want to meet, but aren't able to meet because of funding restraints or restraints because of not adequate training or without knowledge to how to best treat those conditions for the better outcomes for those patients.
Yeah, absolutely. I mean, fantastically put. I think in our last podcast, we talked quite a lot about eczema and how that presents. Is it any different in people in darker skin?
That's a very good question. I think, let me give you a bit of background on that. So what we have to remember is skin of color is more adapted to defending itself against skin because of the origin of equatorial areas where commonly a darker color skin is seen because it has to defend against the skin and protect itself by using melanin to diffract that light. Now, we know that type 5-6 skin is more it does easily tan compared to burn, whereas type 1, 2, 3 tans type 1 doesn't tan as much, but it burns more easily, whereas type 2 tends to tan very slightly but burns also very easily as well. And because of that nature of that skin, what it means is when you have any inflammation or injury to skin from a skin conditions, you have a consequential scarring and pigmentations that's much more significant in skin of color than the Caucasian skin. So that's any condition, whether that be dermatitis, acne, leaves a much more pronounced scar and pigmentation in skin of color. And for a teenager or for someone who's out there on a day-to-day basis having any social interaction for that matter, our face part is the first thing anyone sees. And if your confidence is knocked by some mark or pigmentation or a cosmetic or a skin condition in itself, that has a huge impact on someone's confidence and psychology.
Well, yeah, absolutely. And you were talking about funding in the NHS. It seems that cosmetic procedures and improving people's psychology, in dermatology at least, is not necessarily always at the top of the agenda. But I mean, it sounds like in a lot of cases it can have a really profound effect and impact on people. So it might be something that we as primary care physicians can improve on and think about in the future. You mentioned scarring, you mentioned pigmentation as well. Do skin conditions, particularly eczema, do they present differently?
You're right. Just to address your point there, I think we all understand there's funding restraints. So I think what we can do is be advocates for the patients and learn little things that we can do to make sure that the outcomes are better. So that's hopefully what we'll delve into that in a little bit more detail in a second. But now the other things, like you said, is lichenification from eczema is much more significant in skin of color, especially pigmented lichenification, because it looks a lot more pronounced than if it was the usual skin color. In skin of color, there has been suggestion that eczema can present in a follicular pattern. So you may not get the normal confluent, well-defined eczematous patch that you typically get. It can appear to be a follicular, so sort of almost like folliculitis, follicular dark papular pattern of eczema you can see in skin of color. That is something that's been suggested.
Yeah, okay. I mean, you also mentioned identification and treatment to help prevent these long-term complications. What sort of things can we do better in practice to help prevent those long-term complications with eczema, for instance?
That's so very good point. What I tend to advocate is the reinforcement of those fundamental principles. Emollient, soap, and I keep banging on about it. Avoid the soap. You wash with emollient, liberal emollients, because that's what's going to reduce your that's going to improve your cosmetic outcome long term, because you have less flares, therefore less likely to scar. The thing that we can do as clinicians, I guess, is step up management quickly. If it's not working, reconsider your diagnosis. Is it actually eczema? Could it be something else that's going on? Do you need to refer on early to avoid that impact? Because, like I say again, if it's not managed appropriately, they have a scar left and there's nothing we can do about it. That point is too late. Maybe refer them on earlier on if you're unsure about it, compared to their counterparts.
Brilliant. Thank you very much. And I mean, I think that one of the things about stepping up is, again, that might cause people some worry, is using potent steroids on dark skin. Have you any thoughts on that? Anything that you could reassure us, or anything that we need to be careful of, particularly using potent steroids?
So as a principle, below the neck, I tend to go for Betnovate for treating flares and maybe Umivate for maintenance. It's my standard go-to. Now, of course, with prolonged use of topical steroids, you've got the risks such as hypopigmentation, skin thinning, that those are present, but it's a balance of risks and benefits, isn't it? Psychological or even, physiological well-being. If they've got severe flaring eczema, it's important to treat that. They can't just ignore that. And in that case, you might, again, even step up to Dermovate just for temporarily, just to dampen things down, to get it under control, and then maintenance long term. And again, this is where it comes. I know I keep banging on about it. Routine, where you fix everything else that you can possibly fix around there. And I guess, not often, but in rare cases where you're still struggling to manage that eczema adequately, we might consider other allergic causes and stuff like that as well. But that's a very rare situation. I don't advocate that in a routine eczema management plan at all.
Brill. Thank you very much for that. Well, so I mean, eczema is, I suppose, one or if not the most common thing that we see dermatologically in general practice. Are there any other particular areas that we should be aware of when treating patients, specific ones?
Yes, you're absolutely right. There are a lot of conditions that are particularly more susceptible in skin of color. Just to name a few, like we talked about pigmentation already, and there's scarring. Keloid scarring is an example. Hair loss. There's particular patterns of hair loss that impacts a lot of women in skin of color. That has, again, a huge psychological burden. And folliculitis, because again of the nature of the hair follicle that's different in ethnicities of color. And of course the biggest one that's most apparent, vitiligo.
Brilliant. Well, I mean, if it's okay, we'll come to a couple of those for some specific examples. I mean, we mentioned something about hyperpigmentation with long-term inflammation. You also mentioned melasma. Can you tell us a little bit about that? Because I know it's a big worry for some patients.
You're right. We often get patients coming into practice asking about pigmentation on their face, body, whatever, and it's important that we have some understanding of that. Now, the first thing I do want to say is that we need to be able to identify what is post-inflammatory hyperpigmentation and what's an active rash or an active condition. And of course, and then the worst one of the hyperpigmentative disorders is melasma. So to identify post-inflammatory hyperpigmentation, it tends to be in areas, for example, in acne, where you've had an acne spot, the papules or pustule has burnt itself out and you've left a mark. That would be post-inflammatory hyperpigmentation, as the name says. Okay. Melasma, however, is a condition that affects all ethnicities, particularly women around the time of pregnancy or if they're on the oral contraceptive pill. And it tends to be a larger pigmentary patch, appears typically on the face, cheeks, foreheads, it could be anywhere. And as if you can imagine that a large pigmentary mark can have an impact psychologically significantly on a person, especially if they're worried about how what their appearance is, and that obviously impacts on their confidence. Now, unfortunately, over time, the CCGs across the country have culled back on treating that, not because of any particular reason, but melasma in itself is a condition that's quite difficult to treat. It's a condition you can maintain, just like eczema, but it's impossible to cure. So it's a difficult condition to treat, and the treatment creams and things are quite expensive. So that's one of the reasons that's been called back. So again, there's an unmet need from our patients with regards to the pigmentary disorders here.
Definitely. And it seems like one where we might seek some advice from the community dermatology clinic, but also just appreciate that it exists and it's a real problem for some patients. We talked about post-inflammatory pigmentation there. We also mentioned scars with acne, and that was something that sounds like it can be a really big part of a problem. Could you tell us a bit more about acne scarring and maybe scarring in general?
I think, again, this is a very, very important point. Acne has a huge impact on any teenage person that when they would start flaring up, or even later in life, because of the appearance of the acne themselves, the papules and pustules, but two, because of the significant scarring that can result from acne. That's why it's important to get through the steps and manage them appropriately so that we don't let them scar, because once they're scarred, there's no treatment in the NHS for them. Now, what's worse in skin of color, like we talked about, is the ability to produce melanin, makes those scars not just severe but also pigmented, which means if you compare the same level of scarring in a Caucasian skin to a colored person's skin, it will look much more worse when skin of color because of that pigmented nature of it. And of course, unfortunately, there is nothing we can do to treat that. We can only treat the acne. The Roaccutane will only treat active acne. It does not treat scars, and there is nothing on the NHS we can offer them for that scarring. This is why I advocate very rapid escalation of management in patients of color. Treclin, like I said, is the go-to. Tretinoin, which is essentially a topical version of isotretinoin, is the strongest topical you can get on prescription on the NHS as the first step in mild acne. If it's moderate, straight onto oral antibiotics, tetracyclines. That doesn't work, then at 6 to 8 weeks point, refer on. Don't hold them back. Refer on. We might then, if there are any contraindications to Roaccutane, try a stronger antibiotic. If not, move them straight onto Roaccutane so that we can get it under control. Because, like I say again, I don't know how many times I've said it, there is no treatment for scarring on the NHS, and people have to live with that for the rest of their life.
Yeah. So early identification, taking it seriously, and being aware of these problems later on in life for our patients. Really, really helpful advice. Thanks. We also talked a bit before about scars, such as hypertrophic and keloid scars. What can we do about those? It's something that can be quite limited under the NHS, but what can we do to help our patients?
Thank you. Again, unfortunately, skin of color is more prone to keloiding. And that can happen because, as simple as an insect bite, a scratch, or a post-op wound as well. Okay. And there is not a lot we can do on the NHS for keloids, unfortunately. The things that I think we can do in general practice are things such as, potent or super potent Dermavate or Betnovate creams to try to reduce or relieve symptoms, pain, itching, all those kind of things. And then the other ones that tend to work better because of their better compliance is Helan tape. It's the steroid impregnated tape I tend to find, and literature reports work better because of their compliance, obviously, because you have to rely on that person to put it on every day. Whereas Helan tape, you just stick it on, forget about it, and change it every day. And the more stronger one of that is Betasil tape, which is Betnovate, impregnated betamate. That's even stronger, can help and can be prescribed at the discretion of the GP. It's not recommended commissioning practice. It's at the discretion of you, but you can obviously prescribe the steroid creams to help them. But really and truly, the treatment that they need is intralesional steroids. They need injected steroids into that keloid, and laser and surgical excision if it's still no better, and a further course of steroids to reduce the chance of recurrence, because that's the nightmare with keloids, is that even if you cut it off, the chance of recurrence is significantly high. So we have to minimize that. Now, the only way you can get that on the NHS is if the GP can consider an individual funding request and get that approved by the CCG, where it's impacting. It's in the middle of an orifice where it's blocking, it's catching on a garment or any other clothes, or if it's inflamed significantly, requiring antibiotics, or it meets those funding criteria that are set by the local CCGs. And of course, then you have to see if there is a local service that will do that for you. Luckily, in Birmingham, we do that at the Modality Community Service, but you'll have to find out if there is a local service that will treat that for you. And commonly, the hospital dermatology departments will have lasers and may be able to do that if they have the funding.
Yeah, so again, it's a commissioning sort of thing, but again, maybe a really good chance to speak to your local dermatology, general practice dermatology clinic, and to find out about those things. But as we've talked about many times, counselling the patient about what to expect and risk of recurrence sounds very, very helpful. Another thing, when we were sort of discussing this before, one of the things that surprised me a bit was the amount of alopecia and difficulties with hair that you see. Can you sort of outline that as a problem? And you were also talking about traction alopecia, which was quite fascinating.
That's right. So there's a lot of alopecia that impacts skin of color patients because of the nature of the hair follicle and the physiological differences in the hair follicle. Now, alopecia, traction alopecia in particular, it can be quite significantly related to cultural practices. Some of that might be, in Afro-Caribbean women, it's laying their lines where they use pomade, thick pomade, greasy pomades to lay their lines, which can cause obviously comedomal acne, and of course traction alopecia when you're using tight hair dressings where you're trying to plait your hairs, cane rows and things like that, because of the significant pressure they put on the hair follicle and gradually yank the hair out, and that causes damage to the hair follicle. And over decades, if you continue with that practice, that can lead to permanent hair loss that's irreversible. Really? So it all comes down to counseling. And the other group that we have to also remember is Sikh men who really tightly coil their hair under the turban. That also impacts with traction there as well. And that that is identifying that as a potential cause and addressing that early on, because once it's gone, it's gone.
Sure. So with traction alopecia, once they have traction alopecia, the hair's not going to come back.
You can stop it from getting worse, but even in private practice, all the therapies that we have, minoxidil, PRP, is really, really hard to regrow hair that's gone permanently.
Gosh. Yeah, so certainly something that I hadn't considered very much before, but we should be really aware of. And again, sticking on the hair theme, the last thing I think we're going to talk about was folliculitis. And again, I didn't recognise that this was such an issue in skin of colour. Can you tell us a bit more about that?
Sure. So if we go back to the nature of hair follicles, Afro-Caribbean hair follicle can be curly to coiled type hair, and the hair follicle itself is oval to elliptical in comparison to Caucasian hair, which is oval shaped follicle and can be straight to curly. Still curly, but not as curly. An Asian hair which tends to be round to slightly oval shaped, but the hair tends to be straight or wavy. So the impact of that is that the more curly the hair is, the more likely it's to ingrow, especially if you cut it flat. So one of the biggest things I advise patients is to never cut your hair flat if you're suffering from folliculitis, because the flatter it is, the higher the chance of it growing back and causing a folliculitis at that site. The other things to consider are collared t-shirts, helmets, and things that can irritate those areas, because that can cause folliculitis. Now, starting with probably the first of those conditions is pseudofolliculitis barbae. Is the condition that mimics folliculitis when teenagers start shaving. Again, if you have a curly hair, it's more likely to ingrow and cause the pseudofolliculitis, barbae being the beard area. So again, they're more likely to be affected, and it's typically seen in men, that condition. Now, the worst of those conditions in the folliculitis family is it's a condition referred to as acne cheilodiliosis noosea, or also known as keloidal folliculitis. Now, it typically happens at the nape of the neck, the back of the neck, where there is folliculitis that leads to keloid formation. The papules that you get from folliculitis there become keloids, and they can be sort of collective, couple of papules together, or you can even coalesce and become a plaque of scarring, keloid scarring at the neck. And that is a condition that needs urgent treatment. Please do not sit on that. If you see that, get them on regular antibiotics, and some topical steroids may help, and refer them on to dermatology, your local dermatology department, so they can see what they can do to either escalate antibiotic therapy or add in, again, interlesional steroids and lasers if funding is allowed in that area where there is permission for that service, to treat that as soon as possible. Because again, once that scarring is in place, one, you get hair loss there permanently. Two, it's a common area that's visible when you're walking around and about, so it has a huge psychological impact for anyone suffering from that.
Yeah. And again, I suspect you mentioned before the likelihood of hyperpigmentation as well, with the chronic inflammation, which just adds further difficulties there, doesn't it? And I suppose the last thing, and again, because I wanted to talk about it because it's commonly encountered, was vitiligo and that sort of impact. How can we help our patients with that problem?
I know I'm probably saying the same thing again and again. It all comes down to early identification and appropriate referral where required. Vitiligo is again a condition that we understand so much, but not well enough yet. So it's a matter of the treatment principle are essentially identifying and making sure it is vitiligo and not some hyperpigmentation due to another disorder like eczema, and then two, adequate therapy with either potent topical steroids or even alternative therapy like tacrolimus protopic long term, so that we can switch off that inflammatory reaction or action, so that we minimize that progression of condition. So the treatment aim is minimizing or halting progression. That's the treatment aim of vitiligo, because reversal is very difficult. But in some cases, you may get some slight results if you persist with adequate maintenance therapy. But again, this needs to be managed in secondary care, really, or community dermatology, where we have some expertise in vitiligo. So it's identification and referral early on is the key here. And again, like you said, it's abundant in skin of color.
Yeah. Yeah, and then I suppose following that, if you do have those more permanent skin color changes, again, it's the whichever's available locally for cosmetic changes, because it affects patients.
You're right. Most of the treatment, it comes down to camouflage, unfortunately, because like I said, repigmentation is a really, really difficult process. But if we halt the progress of the condition and treat it adequately, they will have the best chance of repigmentation, if any.
Excellent. Well, brilliant. I mean, well, thank you so much, Dr. Amuthan. We've covered a huge amount today. I think there's going to be lots of people listening at home. They're going to be thinking, how can I learn more about this? So what sort of resources might we be able to access to help learn more about dermatology in skin of colour? What would you recommend?
So there's two things that come to mind. The British Association of Dermatologists do Skin of Colour Day on every year. Typically falls in January. So if you Google that, that's a good resource. The whole day or two of teaching on skin of color conditions, which is really useful. The other one is the Nottingham University website. It has a very good resource index of all the resources of skin of color dermatological conditions, which Amazing. Is really useful. And of course, if ever you want to reach out to me, you can always go on our website, drderm.com, and there's a query form at the top. Submit photos and your details, and someone will get back to you.
Brilliant, yeah, and also the Black Country Skin Club as well, where you're running some educational events. So I think that could be really helpful for people too.
That's it. Yeah. So we with the Black Country Skin Club, we're doing a face-to-face event every other month and a virtual event every other month. So last Wednesday of the month. So if you Google Black Country Skin Club, you should be able to sign up for that, and we'll definitely be covering skin of color there extensively. Brilliant.
Well, thank you so much for your time today, Dr. Amuthan. It's been really, really interesting. I've certainly learnt a heck of a lot about early identification of conditions, being aware of the ways that they might present differently, and also where we want to be treating things a little bit more vigorously to start off with, to make sure that we prevent that inflammatory caused hyperpigmentation and scarring, and just be aware of the differences in our ever increasingly multicultural population, which is really fascinating to hear about that. We would love to have you back at another time. I'm sure we can find some other great topics to cover, but thank you so much for your time. It's been great.
Thank you, Dr. Waldron. It's been great too.
So thank you all for listening. We hope you found this podcast helpful. Please do have a look at the show notes that accompany this episode at GPnotebookpodcast.com, and we'd be very grateful if you would consider following the podcast and leaving us a review on your favourite podcast platform. Feel free to get in touch via social media at GPnotebook or email support@gpnotebook.com if you have any questions, comments or ideas for future podcasts. You should also visit us at GPnotebookeducation.com to register for our virtual GP Notebook study groups and download free resources and shortcuts to help improve the lives of our patients in primary care. Thank you very much.